All right. Hi, everyone. My name is Anjlee Joshi. We really appreciate you being here. We know it's the end of what has probably been a very long day, but glad that you're here to listen to these four individuals talk about a really important topic. Why don't we start off with some introductions? Just name, company, a little bit about what you do.
My name is Katherine Nisbet. I am the Chief Clinical Officer for a behavioral health program here in Phoenix that is called New Freedom. We're an innovative program that takes men and women directly out of incarceration for behavioral health treatment, and we basically are trying to reinvent the reentry center.
Hi everybody, Hamilton Baiden, co-founder and CEO of an organization called Youturn Health. We are a virtual behavioral health program, subclinical in nature. We only exist because the vast majority of people never end up there or to any of the clinical programs. And especially when we're talking about people coming out of jail or prison, obviously we all know lots of issues with mental illness, substance abuse disorder, and we'll get into this, but we always leave it up to the individual to do all the things that we've set up for them. And we just believe that's not a really good recipe for success, and I'm sure we'll dive more into it.
Hey everyone, my name is Darren Webb. I am the co-founder and CEO at Mindset. What we do is we assist those with the mental illness and their caregivers in applying for Social Security disability benefits. We have essentially TurboTaxed that process. What used to take anywhere from 1 to 3 weeks to apply, we get it done in about 45 minutes. We represent that claimant from the initial application, where 80% are denied, all the way through an appeal. We have attorneys on staff that represent them through the entire, and it can take up to 15 months to get these benefits, but we're there to hold their hand and make sure that they're not taken advantage of.
And hello everyone, I'm Johnnie Gasper. I am the Director of Crisis and Justice Systems with Arizona Complete Health, which is a health plan here in the state of Arizona that oversees regional behavioral health authority operations in both southern and northern Arizona, which provides us a unique experience and ability to contract directly for behavioral health crisis services for all members of the community, as well as assist with justice programming in the state as well.
Great. Thank you all. A couple of you mentioned this, but why don't we start off with, what are some of the biggest challenges that you're seeing when it does come to incarcerated individuals trying to re-enter to their communities and just back into day-to-day life?
I would say the biggest thing that ends up happening is also where the data shows. So we have a housing issue, we have transportation concerns, we have family dynamics that come into play. A lot of reintegration is also about taking individuals that have extensive incarceration history, sometimes upwards of 17, 18, 45 years, and being able to reintegrate them into a technology world that they're not used to. So that can present a really big challenge, in addition to just some of the socioeconomic ones of just being able to leave prison and have a stable place to land.
Let me go last.
Johnnie, kick down to you.
Sure, yeah. So I'll kind of address it on two fronts. I think on the front end, we're changing a culture in the first responder system, particularly with police departments, to identify and service individuals with mental illness effectively in the community. And on the back end, I think as you touched on, right, reentry is difficult. Connection to care, I think even something as simple as a scheduled release is significantly impactful when we're trying to connect individuals as they reenter into the community.
So we deal with, more jails and less prisons, so those that are kind of in and out pretty quickly. But, lack of social support from caregivers, whether that's a mother or father, a good friend, transportation, communication, even just having a cell phone when you need to call your probation officer and you can't, they're going to come and arrest you. So just the basic necessities of life, and that just comes down to funding, right? Those that are getting out, their lack of funds is really an issue, and that's something that we're personally trying to help, but also, what can local governments do? Are there grants that can be given? I know there's, a lot of stuff that's happening that can be innovative, but, the basic necessity that we're seeing on the front end is lack of funds to do what they need to do to, stay out.
All right, the reason I went last is because when you get out of jail or prison, you have to do everything that everyone just said. So let's just talk real world. I get out of prison, I got to find a job. I've got to reconnect with my family because they're pissed off at me. I've got to get Social Security benefits or disability benefits. I got to reinstate Medicaid. And oh, by the way, I'm on Suboxone because I was a heroin addict. And all of these great people have all of these great programs set up, but the way that we deal with this is we say to me, who's getting out of jail or prison, you've got all these great programs, now use them. So I want you to just ask a rhetorical question. If you believe mental health and substance use is a brain disorder, or at least we could probably all agree that the people that struggle with this have something called irrational thinking. And I'm a recovered alcoholic. I struggle with mental illness. I absolutely had irrational thinking. So we're telling the person that's getting out, hey, you by definition have irrational thinking, but you be rational and use all of these great resources. It's the dumbest thing I've ever heard in my life. I'm sorry, but I'm really blunt about this stuff. So what we believe is we need to give that individual another individual that's already done this, that is of sound body, mind, and spirit, that's lived through this, that can navigate them through the challenges. And what we say, it's a paradigm shift. Instead of relying Katherine to do all the right things and use all of these great tools, we're going to give her another Katherine that's been there, done that, and really take responsibility for her doing all those right things. And at the same time, we're doing it for the family as well. Because so many times they're not educated. I mean, when I got sober, my wife she didn't even know what an alcoholic was, much less I didn't know what an alcoholic was. But her and my 3 kids were losing their mind because they didn't know what was wrong with me. They were struggling first.
I want to piggyback. There is a saying that orange talks to orange better than anybody else can. The peer support model is a huge, huge piece that has to be integrated when we have men and women leaving incarceration. At New Freedom, about 80% of our workforce alone is peer support certified with a history of incarceration. So when members enroll in our services, everyone that they can connect with has extensive either professional history or personal history with incarceration, because it creates an immediate trust and immediate, oh, you did this, I can do it too. You've been out of prison for 5 years, I bet I could be out of prison as well.
Can I say one thing? Perfect tag onto this. Are there anybody in the room that's a veteran? If you are, raise your hand. Matt, I know you're a veteran, so raise your hand. All right, so if Matt's struggling with substance use disorder and he's a veteran and I call him, he's not talking to me because I'm not a veteran. So I'm just piggybacking on what you said, orange talks to orange. That's the way it is, guys. And a mom who's dealing with a kid that's a heroin addict that's been in prison, she wants to talk to another mom that's had a son in prison dealing with the same thing. So it's the same philosophy.
No problem at all. It's a great point. So outside of peer support, which is a crucial type of support individuals need, all of you highlighted multiple challenges these people face, not just in their day-to-day life, but with all the systems they have to encounter. So what are some of the supports that you feel like really are crucial that each of your organizations provide?
I would say one of the biggest ones that New Freedom provides is integration between housing and behavioral health services. So we offer supported housing, which on the day of release that a member can move into, and we also pick them up from the gate. So there's a lot of our members that don't have family support, that might have burned bridges while they've been incarcerated. They might have had this revolving door of in and out, not to mention the amount of substance use and now undiagnosed mental health issues that come along with being incarcerated. And our program specifically works on the housing, but also this target population for post-incarceration syndrome, which is a cluster of symptoms that we have started identifying that really hits this population with antisocial personality traits, reactive substance use, institutionalized trauma, post-traumatic stress, and sensory deprivation. So we try to target all of those things in addition to the social determinants of health of housing and transportation and family and benefits and all of those things, because what we're seeing is when individuals come out, it gives them a little bit of a longer runway in addition to getting their ID, complying with probation or parole or both, depending, immigration status, driver's licenses, in addition to all of these other things, it's a little bit longer of a runway to be a little bit more successful after leaving incarceration.
Want to keep the order?
Sure, why not? We'll switch it up next time.
So my personal opinion is the biggest challenge is engagement. Whether it's somebody getting out of jail or prison, or whether it's just me who had a job and was running a big company and I was struggling. What we know is if people get engaged with treatment or positive change and they remain engaged, most people get better. So again, if I'm getting out and I'm using New Freedom and I'm following all their rules and I'm doing everything they're saying and I'm using all of their tools, I probably got a pretty damn good chance to make it. But what happens when I get out of jail and I'm on Suboxone? and the very first thing I do is everything else except take my Suboxone. It's a recipe for disaster. And then let's say I'm on Suboxone and I go to a Narcotics Anonymous meeting, and if anybody in this room is in recovery, I apologize, I'm probably gonna piss you off, and I don't care because we need to talk about this. You go to a Narcotics Anonymous meeting and somebody tells you you're not sober because you're on Suboxone. That is criminal in my opinion. So many people say, well, I shouldn't take it, and the next thing you know, they die from fentanyl overdose. So to me, it's all about engagement, and I just want to say this really clear. I don't care if you ever use the name Youturn Health again, but we have to start thinking about this with a different philosophy instead of if you use, you're bad, you're not in recovery. It shouldn't be that way. It should be very different.
Got it. So there's so many different processes that take place when you apply for disability benefits. Again, communication, I think, being one of the largest. We get about 29 pounds of mail every single day. We are copied on all of the mail that goes out to Social Security. If Social Security tells one of the claimants that's applying that they want to hear from you in 7 days and they don't hear from you, you've got one more chance or your application's going in the trash. So for us, it's staying on top of that, getting in touch for Social Security on their behalf. Another thing is we've partnered with a company called True Connect, which is the largest lifeline phone provider in the United States. Every single one of our claimants gets a free cell phone, unlimited data, unlimited text messaging, not only to stay in touch with Social Security, but to stay in touch with us, and then more importantly, to stay in touch with their family, access to ride-sharing services and things of that nature. So I think one of the most damning statistics that we have is our average claimant is a 41-year-old female with bipolar PTSD and has never applied for disability benefits before. She was diagnosed 20 years ago. So for 20 years, this program has been around where she was eligible and hasn't applied. And when we ask them why, they say, it's overwhelming. They've spoken with an attorney before or a local representative. They get the paperwork that's mailed to them, and the stack is this thick. That's it. They're out the door. So, we try to walk them through that entire process, understanding that the average application process is going to take 15 months, but, we're here with them through the entire thing.
Yeah, I would say 24/7 access to care is one of the things that we're trying to address as a health plan, right? I think it's wonderful when you're in a stable environment, but when you're returning to the community and you're not in a congregate setting where you may be receiving services 24/7, you need access to care, you need someone to call, right? And I think that's important both on the front and back end, because to address recidivism, right, we need to ensure that individuals have a resource available that's available 24/7, whether that's a crisis line, a mobile team, whether that's supports in the community, peer supports, et cetera. If those individuals or folks you can't call on 24/7 to support your needs, whether that be behavioral health in nature or substance use in nature, right, you need to have those levels of care there for you all the time, right? Some of the troubles that we receive, particularly as a health plan that we want to address, occur at 2 a.m., right? When you need that support at 2 a.m., it's not 8 to 5.
Thank you. So we're going to take a little bit of pivot from the individual being incarcerated. It's not new news, but I think we see more videos of it now between social media and the news. But tell me what you think, what really first responders in particular really need in terms of training and support to prevent some of these individuals with mental health and substance use from ending up in the system, which is often what we see now.
Can I go last?
We're going to start with Johnnie anyway.
So I'll kick us off. One of the things we offer as a health plan and as a regional behavioral health authority to first responders is both mental health first aid. We're partners on CIT. We offer SISM training for them as well. And then in addition to that, we do crisis system overviews. We're lucky in the state of Arizona to have a Medicaid funded crisis system that's available 24/7, so they have extra tools. So I'd say despite us offering all these trainings and partnerships with these first responders and law enforcement officers, right, one of the most important things we give them is a tool in the toolbox, right? They have a number to call 24/7. They get an expedited response. We say, internally, this is a preferred customer to ensure that they're receiving responses as efficiently as possible into the community. Our response times for first responders when we send a mobile team hover around 30 minutes in southern and northern Arizona. So again, not only do we need to provide adequate training, but on the back end, we also need to do something and understand that these individuals aren't going to be clinical, right? There may be escalating needs, and as those needs escalate, right, folks that call 911 don't generally call because someone's being peaceful in the community. So with escalated behaviors, we need to be able to both de-escalate and address that in real time with a clinical or a behavioral health professional that can respond on scene or telephonically to support those officers in the community.
So I don't have as much experience with first responders on the business side. Personally, I have a loved one with schizophrenia. I've been a caregiver for the past 15 years, and I've gotten more than enough calls from first responders, whether he was arrested or in the hospital, where they can really only tell me, we have your loved one, and that's it. I think communication needs to be opened up between caregivers and loved ones to allow them to help, their loved one that's going through it, whether it's letting them know the type of medication that they can take versus they can't take, or, kind of what his attitude is. I think something really big needs to happen there to allow for better care for those that are suffering.
So this doesn't have anything to do with just first responders. This has to do with everything. And again, I'm only talking about behavioral health, but I think we have to change the narrative. We have to change the way we talk about it. And more importantly, we have to talk about it. I'll give you an example. When I was 19 years of age, I had a full academic scholarship to a college in Charleston, South Carolina. And one night I went out and I woke up in the middle of a river. I'm not kidding. My Jeep was beside me, bubbling down in 25 feet of water. I was literally wasted out of my mind. I had no idea if anybody was in the car with me or not. Now, here's the interesting part of that story. I drank for another 25 years. That was not my bottom. That was just a bad night. I drank too much, just had a bad night, fell asleep, not a big deal. The reason I went to treatment is because I woke up one morning and my wife said, I'm not doing this anymore, I'm done. I don't love you, I love you, but I'm not in love with you and I'm done. And that's why I raised my hand and went to treatment. We have to change the narrative on this. Not everybody has to hit bottom and go to treatment. That is a fallacy, it just is. It doesn't make a really good movie or TV show if at 25 years of age I course correct my behavior and learn to drink like a normal person. Believe it or not, that can happen. And if you don't believe me, how many people in this room know someone that drank too much and then they got into CrossFit or religion and they don't drink as much? Everybody knows somebody that does that. Why the hell is that person not in as much as recovery as I am? So if we start talking about this as real people, I do this every time I talk. Everybody raise your right hand. Everybody, you guys got to play along. Raise your right hand. All right, if you or your loved one, someone that you know, has ever struggled with anxiety, depression, mental illness, substance use disorder, and here's the caveat, stress is included, put your hand down. You or your loved one. No one in this room, you've never been stressed or you've never had a family member stressed? Not you behind you. Oh, no. Okay, that's what I mean. Everybody puts their hand down. Everyone in this room has struggled with this. So stigma exists. Let's stop acting like it doesn't and let's deal with it and talk real about this stuff. That's what will change the narrative on all of this.
I think any level of law enforcement, I think there's a two-way perception. There's a perception of law enforcement on individuals that enter the criminal justice system because of mental health or substance use. And then there's also the perception of the person entering the criminal justice system on law enforcement. And I think really the dialogue and communication between those two parties can go a really long way in understanding with education of what is happening on both sides. Law enforcement is not exempt from substance use and criminal activity, just as the individual is not exempt from, they could have been in law enforcement themselves. So I think when you start breaking down some of those barriers between the two, it really opens up the conversation between how does one help the other. I have been fortunate to work in law enforcement. I work for the Arizona Department of Corrections, and education goes a really long way in trying to get someone to understand the struggles of developing empathy for others. So I think in working with first responders and how they basically are working with the entire population of having those little moments of empathy goes a long way in how crisis system works, in how using providers throughout those systems work. There was a great example earlier of here in Arizona, we have Connections AZ, where law enforcement can literally take an individual that's in a crisis and have them there, and then their job is done because they understood it was a behavioral health crisis and not a criminal crisis. So I think there's a lot that can happen between the bridge between those two populations.
I add one thing to what she said, and the other way, and I know you'll agree with this, and even though we just met, the other place that education is extremely important is the family. The family does not have the first frickin' clue what's going on. There was a statistic recently that says that 26% of American workers in this country are now going home to an individual in their family that is actively struggling with a behavioral health issue. And I lived it. My wife, all my wife knew was I didn't drink like a normal person. And she actually loved when I drank. It was when I didn't drink that was the problem. But she wanted me to drink like a normal person. Well, let's come to the reality of it. I'm not capable of that. And I now know that. I do believe that I could have learned a little bit earlier to change that behavior where I wouldn't have gotten there. But education is key. And we could talk more about that, but I just wanted to tag on to that.
Absolutely. Education between any level whether it's criminal involvement without addiction or addiction with criminal involvement or any of those in between. I think when families start understanding not only the addiction and the mental illness and the active part of it, but also the recovery aspects and being able to understand what that journey looks like and that things are not going to go exactly the way they think it's going to go, especially because of television and things like that. I think that goes a really long way in bridging all of this level of empathy and understanding and the education piece.
Real quick on first responders, and I would suggest you guys look this up, but New York City last year did a pilot program where if someone calls 911 and says that one of their loved ones or someone they know is having a crisis behavioral, they're now sending a psychologist, a case manager, and an officer. And I think that reduced arrests for that population by like 60%. So it can be done, it should be funded, it should be piloted in every city across the United States, and that's just common sense.
Yeah,
Johnnie,
that's exactly what I was actually going to touch on here in the state of Arizona, because I think that's what's important, right? Up until last year, we didn't have a 3-digit number for community members or family members to call when they identified a behavioral health crisis, right? So what other number do I call when I need help? I call 911. Right? I assume someone's going to respond. I assume they're going to help me, whether it's PD, fire, EMS. My assumption is that's who I call when I need assistance. And up until last year, that there wasn't an alternative. So I agree. Here in the state of Arizona, we piloted in Tucson and Pima County. We have 3 co-located crisis professionals that are affiliated with the statewide crisis line that sit there, have access to the computer-aided dispatch system through Tucson 911 and Pima County 911, as well as the rest of southern Arizona, since TPD and 911 systems are linked together. And so they have the capacity to not only take those calls, but also start to shift the culture with the folks over at 911 to understand this is what a behavioral health crisis looks like. These are the folks that can address it and build that trust and start to shift that understanding so we can take more calls from that system on the behavioral health side.
Great. Let's shift a little bit because it's being brought up to caregivers and families. Tell me a little bit about the supports you're providing to caregivers and families, whether it's while their loved one is incarcerated, where they may have no touch at all if they choose, or limited touch, but also when their family member is now re-entering the system.
That varies. I think caregivers play a really important role in the reintegration and being able to start a sense of community. It also goes a lot into pro-social behaviors. It goes a lot into how that individual feels connected to be able to sustain and motivated to want to stay out of incarceration. A sense of family can be blood-related, non-blood-related, all of those different things, and it becomes really important that there is dialogue. It doesn't necessarily have to be acceptance, but there can be dialogue. There can be a conversation to where this is maybe what I did in prison to maybe improve myself. Maybe I was in a vocational program, or maybe I got my GED. There can be those kind of strives in addition to once leaving incarceration. These are the things I'm going to try to do different this time to not go back. Caregivers also play a really large role in motivation and engagement in treatment. I have seen time and time again that I, as the member, I want to engage with my family. I want to be there. And they call, and at the drop of the hat, they're like, hey, I need you to come home, and you need to be here to take care of mom. Instant. I will leave everything I have ever been doing that could have been really beneficial for me, and I will go home and I will do that. Because that is so important for them, is to have that family being like, nope, you get to come back. We want you back. That is a huge motivator to engage in treatment, to stay in treatment, and also bring the family into treatment for understanding what they have going on. In our program, we have several instances of bringing the family into our program and being able for them to help understand what that journey looks like. What are they really doing? Because, you're not home, and I thought you were coming home, and now you're not, so what does this look like? What are you really doing? And then they get to start to see that evolution, so then boundaries can be discussed and relapse prevention can be discussed, and what does this look like when you actually do leave the program or now you're out on your own. So caregivers play a vital role.
So we think family members, I want to tag on one thing Katherine said, is we never define family, because if Darren's my buddy from when I was 3 years of age, and we've been friends till my age of 54, and he's struggling with behavioral health issue, that could affect me just as much as if my wife was struggling. And so he gets to, the individual that we're working with gets to tell us who their family is. We think education is so important. We created a platform I hope nobody in the room is from Netflix because I'm going to probably get in trouble. But I call it Netflix for behavioral health. It is the largest collection of counselor-led, evidence-based videos on the planet. And there's a couple of things about it that are really important and very different. Number one, it's anonymous and confidential. So when we launch this in a commercial setting, there's no stigma whatsoever. So instead of Darren having to raise his hand and go to HR and say, look, I think I'm struggling, or call the EAP, he goes, he starts to learn, get hope and advice from the journey of others. We also make it available to the family as well. About half the content is for the family. For instance, we have a whole video series on what is MAT and why is my loved one on it? What happens when my loved one's in treatment? What is the neurobiology of addiction? What happens when the person switches from partying to actual full-blown addiction? But the coolest thing about our platform is the vibe of the platform. Whether you like it or not, we talk a lot like I talk. It's very real talk. These are not actors. These are not avatars. It's a different philosophy of we don't care what brought you here. We're going to help you no matter what it is. And that philosophy engenders people. I'll be honest with you, we didn't want to create this. But what happened was there was a think tank in Washington called the Addiction Policy Forum, and they do really good work. And they got given a lot of money by the federal government to create the nation's response to the opioid epidemic. Do you know them? You do? Oh boy, you're not going to be happy with this. So they created a black and white cartoon. That was their response to the opioid epidemic. And there's a video that Johnnie may know of. It's called The Hijacker, and it's illustrating what happens to your brain when you go from heavy use to full-blown addiction. This is no BS. When the businessman, black and white cartoons, walking down the street, when his brain switches to addiction, syringes grow out of his head. So if you're on opioids, or your kid's on opioids, or you're going to run the other way. No one wanted to watch it. And so we were like, crap, we got to create this ourselves, and that's what we did.
I think caregivers should be paid. There's a company in New York called Freedom Care, which facilitates the payments to caregivers. And I think that's only if you're a caregiver for someone 65 or older. But since I've been an adult, from 21 years up to 35 now, 15% of every check that I get every 2 weeks goes into an emergency account to deal with my loved one who's battling schizophrenia, because I know the nonsense is going to begin sometime or later. I think just the amount of stress that caregivers go under, it's a lot of work. It's psychological for yourself as well, just not physical. Regarding institutions and jails and prisons, communication is lacking so much. Everything is the caregiver chasing to find out information. There's no outbound from the facility to the caregiver. Something has to be done about that. We work directly with social workers and case managers. There's, one social worker, case manager for every 300 inmates. That is not sustainable. So, whether that's getting their hiring practices correct and just making sure that they're staffed properly, that will, help out a lot.
And this is when it doesn't benefit me to be on the tail end. I think that those were all fantastic summaries. I would just, again, piggyback on what Hamilton said. I think folks that are part of your support system are built in. I think it shouldn't just be family and caregivers, it could be friends. And I think an openness as a system, both as a contracted provider, as a health plan, or a supporting entity, we have to be open to what that looks like to each individual. And I think we need to build off of that.
Hey, one statistic on the family, Darren brought it up. The Snyder Health Institute did a study on family members of addicts. They are 5 times more likely to be hospitalized in a given year than the general population. So think about it. You're always waiting for that phone call. It's never resolved. It's always a chance that something's going to happen. And what we see more than ever is when you've got someone in jail or prison, the people that aren't going to the phones or to the tablets to talk to their loved ones, it's the people with behavioral health issues, because the loved ones get to a point, they don't understand it, they don't get it, they think, my wife thought I just didn't love her enough. That's literally what she told me. You don't love me enough to drink like a normal person. And I'll be honest with you, I didn't know the answer to that question. I really didn't, because I didn't understand what I was dealing with, and that's why education is so key.
Johnnie, I'd like to start with you on this one. Inevitably, when we talk about this population, the topic of recidivism comes up. How do you all think about whether it's prevention or supporting individuals so they're not either re-entering the system or, like Hamilton mentioned, maybe just waiting for the next time they're going to end up in an ER or inpatient?
Yeah, so we're addressing this kind of in two ways, and I think it's important to view it both. I agree at the entry point and re-entry. I think we evaluate criminogenic risk with our peers that are effectively working with individuals at the re-entry point to identify those that are maybe higher risk, to assist more with supporting services. We try and look at outcomes. Thankfully, we're with the health plan, so we can identify what types of services through claims benefit these individuals and try and assist with that, right? And then try and share that with our contracted providers in an effort to try and build out programming for those in need. On the front end, right, one of the important things and one of the reasons that we're so focused on first responders is because we do know these folks, but there is limited touch to outpatient behavioral health systems. So if I call 911 every day, or folks call 911 for me every day, there isn't communication often between the 911 system and our community stakeholders or providers, right? So even if I'm affiliated with an outpatient entity, because I haven't gone to an emergency department, because I haven't been to an inpatient unit or observation unit, I might not know that individual is called the law enforcement department 15, 20, 30 times, 100 times in a month. So what we're doing is working directly with the 911 system and our first responders there to identify those members and coordinate directly with those providers, because there is a gap, as we discussed earlier, right? There's a gap in the system because there isn't that communication point between the 911 system before they are arrested, right? Because we do place pressure on a first responder. If I go to see the same person in the community 20 times, there's going to be a likelihood that I'm going to charge them more often, right? Which is going to result in an arrest and oftentimes, again, recidivating into the system.
My colleagues here are much more qualified to talk about, this particular issue than myself. But, and again, I think if we knew the answer for that, we probably would be out of a job. So, it does need to be implemented. But, the prisons and jails that we partner with, they're called frequent flyers. They're inmates that are in every 3 months, and that's one thing we're trying to stop. And again, I just think it's funding. They're going in and out for the same petty crimes of stealing something from Walmart or 7-Eleven. So, from my point of view, it's lack of access to funds, and kind of everything, takes off from there.
So I think Johnnie said something really interesting. Not everybody needs the same treatment. We have to change the narrative that this is not black and white. For 70 years, if you had a substance use disorder, there's one way to treat it, right? Quit drinking today, quit drinking for the rest of your life. You can go to AA, you can go to NA, or you can go to treatment, and then do what they tell you to do for the rest of your life. That's just not true. Not everybody has to do that. And so not everybody needs intense, assertive community engagement coaching that we offer. Some people just need education. They need to learn. They need to understand. They need to get hope and advice from the journey of others. But I think, and I can only speak on behavioral health, I think the other thing is we have to change the definitions. Like recovery for so long has meant what? You don't use any mind-altering substances. So I'm going to throw something out there. Some of you may get up and leave when I say this, so I'm going to go apologize up front. Let's say we have a guy that's addicted to heroin that goes to the Pinal County Jail, and we get him on Suboxone, and he gets out of jail, and he gets his life back together, and his family loves him, and he gets a job, and he's healthy. The health plan loves him because he's not taking all this medication anymore, but he lives in the state of Arizona where marijuana is legal, and he takes a gummy every night to go to bed. Do we care? I don't care. We need to be measuring whether the guy's healthy, whether he's happy, whether his family likes him, does he have a job, is he breaking the law, and most importantly, is he healthy? If you're in recovery, you will say that person's not in recovery. Why? That's my personal opinion, and I know it doesn't sit well with everyone else, but if we start talking that way, we will get more people into, quote, recovery than we are today.
I'm going to focus on recidivism. So that's kind of tricky for me because there are so many different reasons of why people go into prison. There are a lot of different reasons of why people go to jail. I've worked with individuals that saw prison as home. So I actually had a client once tell me that they came out of prison for vacation. They had been in the institution since they were 16 years old, and they would get parole just so that they could come out, make some money, see their friends, have a girlfriend, and then basically plan out their next crime to go back into the institution. Because they had respect, they had a community, they had a gang, they had people in there that loved them and how they treated them, and they understood the rules. That's a tough way of how you determine who goes back and who doesn't, is how they come out and you start working on those identity issues and their recovery issues. So recidivism really comes down to the motivation of finding community outside of the only community they might have only known. There's a lot of power that goes into the dynamics of an institution, of a prison yard. There's a lot of dynamics that go into gangs. There's a lot of those things that, as a practitioner, I had to learn and understand because I knew family wasn't what family, everybody thinks family is. There's lots of different families. And recidivism is, am I willing to take a leap to stop all of the things I've ever known, which is criminal behavior, substance use? Am I willing to stop all of those things to do this thing you say is going to make it better? That I'm going to be out here in the community longer, I'm going to be a law-abiding citizen, and I'm going to do all of these things, even when it gets really hard, because I know how to make it really easy, is I steal a car, and I get high, and I rob a house, and I get a gun, and then I start selling drugs, and I do all of these things because going back is really easy because I know how that system works, and sometimes it's much more effective for me. So recidivism is this really tricky thing that's only measured, after someone's been out of incarceration for 3 years, when their highest risk is actually years 4 through 9 of actually returning to incarceration. So it's really hard, especially in the state of Arizona, where recidivism right now is 45%. It's not a great number, especially when you have 44,000 incarcerated and 18,000 return to our communities every year. So we always have to consider recidivism looks very different to each and every individual because it could be a mental health crisis, it could be substance use, it could be a lack of funds, or it could be the fact that I just don't know how to do this. I once worked with a 65-year-old man that was released after 45 years of incarceration that said, I don't understand Phoenix, this used to all be orange groves. His risk of recidivism was much higher than the 23-year-old that just got out for smoking marijuana and having possession. Because for him, it was much easier for him to go back into the institution where he had respect, he had health care, he had 3 hots and a cot, and he had everything else he could ever imagine. Because out here, he had no family because they'd all passed away since he'd been incarcerated. So recidivism is very tricky. It's not necessarily your crime, it's not necessarily all those things, it's about that individual and their motivation of staying out of incarceration and the community supports and the healthcare supports that are there for them when they leave.
I think you hit it right on the nose as far as community support, but also government support. Like, what makes that person only feel community when they're in jail, right? Is this person a byproduct of a single-parent household whose mom doesn't get home until 8 p.m., he's out of school at 2 p.m., so for 6 hours of the day as a 10-year-old, he's home by himself. What does he do, right? He looks out the door, he goes outside, gang members get to him, and that's who rose him. That's his community. At the beginning of COVID in New York City was one of the kind of last cities to close their schools, and that's because 30% of all of the students, that's where they get their hot breakfast from, right? After school programs, rec centers, like that's where it starts, and I think will help with that problem.
So last question here, and a little bit broad, but what I appreciate about all of you today is you've consistently talked about the individual, the caregiver, the family. And I imagine you all go back and have to have some very interesting conversations with customers or other individuals who are not maybe as closely related to being on the ground. What do you wish more people knew, either in those conversations or even at the conference here today, about this intersection between an incarcerated individual, the justice system, and mental behavioral health?
I'll go. There are so many organizations, city-based, state-based, nationally based, that are assisting this community. We've gone and partnered with the jails, and we wouldn't even know that there's 10 other organizations that are helping. So I think what would also help is if there's kind of more communication, not being siloed when you do these partnerships, and understanding that, hey, if we're able to get a more holistic view of all of the organizations that are there in an individual facility, things will be a lot smoother. That's just how I look at it.
Yeah, I'd build on that because we feel similarly in the state of Arizona. I think this is still a growing piece for us as well. What's least restrictive and clinically appropriate is oftentimes better for everybody who's engaged with that individual. We heard about kind of connections and their law enforcement drop point. If I'm a first responder and I can drop someone at an observation unit and it takes me 10 minutes versus booking them and that takes me an hour, why wouldn't I do that? It's great for me. It's more clinically appropriate for that member. It's less restrictive from a cost. If I put my health plan hat on here, right, it's better for me as well. They're going to get the level of care that they need. They're not going to an emergency department. They're not going directly to an inpatient unit. So I think as we kind of build that focus, it is beneficial not only for that member, for that community member, but it's also beneficial for the system to get these folks the right levels of care and their needs met.
I think it's understanding that this population, you get to see the most amount of change you could probably ever imagine. I've worked in the recovery field now 17 years, and I am constantly in awe of the amount of changes that people will make in their lives to truly just be in their lives, to find that happiness and acceptance and joy. For some, it's that this population can be scary. Individuals kind of look a certain way and talk a certain way, and if you don't really know what that looks like, it can be really intimidating. But they're all just big teddy bears. So I think it's really just having a love for working with this population and knowing that their behavioral health challenges are going to show when they feel the most acceptance, love, and trust from their provider. I think in what I have seen is that pink cloud of usually individuals leaving incarceration kind of pops at about 30 to 45 days, and then we really see this individual and start identifying some really true mental health needs, especially with post-traumatic stress from the institution itself. I myself, when I worked in the institution, I think I saw fights and rioting at least once a week. Maybe not rioting, but I would say fights and pretty big events. So imagine being the one living in that institution. So I think there's a lot of empathy that can be developed for this population and understanding that there's a lot of underlying behavioral health that they will do everything they can do to deny, in addition to substance use. They will do everything in their power to say, no, I got it, I'm gonna get a job, I'm gonna get a house, I'm gonna start taking care of my kids and paying off all my bills, I'm gonna do all of these things and it's gonna be really amazing. And then the next thing you know, all of a sudden, we have undiagnosed bipolar disorder. We have undiagnosed anxiety and depression, and we have all of these things start creeping up, and it's being able to utilize a lot of their supports of their caregivers, their family, peer supports, and providers to be able to connect them to the gaps using whatever means necessary.
I think the biggest thing is, and this tags on to what Katherine said, and she said a lot of different things, but what I heard her say is treat people as human beings. When we talk about behavioral health, look, I've already said it, stigma exists. I'm a recovered alcoholic. I've been sober for 11 and a half years, and if I meet somebody else that's an active alcoholic, I immediately go, why? Like, I have stigma against it, and I lived it. And so if I have stigma against it, everybody else does too. But if we treat that individual as a human being, not as an addict, not as an alcoholic, not as someone with schizophrenia, we're all humans. And if you treat someone that way, what I always say is most people want to get better. I've never met somebody that's gotten into recovery and said, I really like that life a lot better. Most people want to get better. They just don't want to raise their hand and stop today and stop forever. If we treat them as a human being and get them moving forward, most people will follow along. Look, we're not going to save everybody. That's the really sad part about this, but we can get people moving in the right direction. We just have to treat them that way.
Thank you all. We actually have a couple of minutes for questions if anybody has any. There's a microphone right there if you want to come on up. Or you can shout it and I'll repeat the question if that's easier.
Excuse me. Okay. Thank you so much for this. This was amazing. Curious your thoughts on the Biden administration and the 1115 waiver that they're doing for the justice-involved population and how you see that being, implemented.
So I think there's a lot to learn there, right? I would say that the opportunity to provide additional services is always a benefit. I think we're still trying to figure out how we're going to leverage that. But again, historically, from an outpatient perspective, if my assigned member was incarcerated, or even if they were detained, right, your access, your Medicaid funding turns off immediately, right? And the benefit then that you had from your case manager that you maybe built a relationship with, your therapist, et cetera, becomes very nuanced at the minimum. It has to, that provider has to be then open without funding to even providing that level of care. So I think expansion in that direction is largely beneficial. I think that if there's relationships that have been built, we can certainly leverage them to expand upon that. But I think there's still a lot of growth that we need to do from a provider perspective to ensure that we have the adequate network to provide services in a detention center as well.
Yeah, I would just add to that, it determines what Medicaid's going to cover too. Because Medicaid will pay for peer support. You cannot run a business off of what Medicaid pays you for peer support. You can't do it. So while it's great that more people are getting coverage, what the hell are they actually getting coverage for?
My name is James Corbett. My question is through the lens of crisis care and through the SAMHSA guidelines for crisis care. They break into 3 domains: someone to call, someone to respond, some place to go. I want to make sure everybody in the room knows, because we kind of talked around it, that 988 is available in every state right now. It's not advertised. 80% of the calls when you call 988 are resolved in the community. Never need to send 911 there. Never need to have people brought out of the house to a hospital. So that's a resource in every state right now. It's just that only 15% of the country knows about it because every state gets to advertise it as they desire. My question's in the second domain, a mobile crisis team. So what I see in working in this across the country is that, particularly in the era where opioid settlement dollars are now available, there's a big fight happening about who gets to go, and you know where I'm going, you shake your head already, who gets to go to that mobile crisis recovery support in the community. So in some places, the county has approved it, but the city says no because they don't want the police department to come there. So I just want to understand from your perspective, I see it that it can work in both ways, that at times, and police departments I talk to say that we're not sending, and this is their quote, they said, I'm not sending a 220-pound musclehead guy there. I'm sending somebody who's trained and who should be a part of the team and can transport faster to the facility. So where do you stand on, can police be a part of that mobile crisis team in plain clothes? Is it a possibility or is it not?
Yeah, so I'll take the initial stab, and if folks want to add. So I'll talk a little bit about how it's arranged in Arizona. So prior to the 988 going live, we did already have crisis lines that were embedded in 3 regions in Arizona. So when 988 did go live, it rolled into a statewide crisis system that's been live, at least at the crisis line level, since October 1st of this year. So the benefit then was that, and following SAMHSA's best practice, that is the air traffic control model. Everything begins to get routed through the 988 system and the crisis line. What that does, and it allows us to do as a health plan and as the contractor, is then we get to put some specs or at least some requirements on those mobile crisis responders as well as the crisis line. One of the things that we've done that's been largely beneficial is model some of that around the 911 system. So all of our mobile teams in the community are GPS linked, whether that both in their vehicles as well as in their cell phones. So we don't just dispatch a team. We dispatch the team that's the closest to you in each of the communities within the state of Arizona. And the benefit of that, particularly as we link those to law enforcement calls where we might do something like a dual dispatch for a high acuity call, is we can coordinate with law enforcement and say, we can stage nearby, we'll be there in 30 minutes, right? And so we're able to offer up more information, we're able to offer up those clinical services, and also just really tell them where we're at and how often we can respond and when. So I think it's that open level of dialogue and communication that benefits that system. And again, within the state of Arizona, I think it's largely benefited us because it really has been modeled as kind of a best practice through SAMHSA.
Last one, thank you.
Okay, hi, I'm Joy. I'm with Futuro Health, it's a nonprofit, and you brought up peer support specialists as a really key role, and I'm coming at this from a workforce development lens. So folks that come out of the system and want work are perfectly trained peer support folks, right? And we don't have a national peer support certification, right? We all have different states. Our company's based in California, but we're national. So we view PSS as a gateway occupation for mental and behavioral health careers. And I'm curious what you think about that, because there's substance use disorder, there's apprenticeship opportunities, there's such, it sounds like all of us obviously are big advocates as well, but could workforce be a way to reduce recidivism, but particularly with mental health? And I'm speaking as a daughter of bipolar person, and talk about stigma, right? Not diagnosed until she was in her 60s, and also with a developmentally disabled brother who can't access mental health care. So I'm thinking about it from lots of different places, but workforce with that empathy at heart, which I really appreciate that all of you are saying, but Katherine's particularly saying out loud. Really curious, because I think we could solve a lot of problems with, well, this is me, I'm biased, I'm sorry, leading the witness, but I would love to hear your input on what workforce solutions could actually be put together in a holistic way.
Yeah, do you want me to take that? I will just tell you.
Arizona is unique, and the Arizona Department of Corrections, Rehabilitation Reentry, they actually do a peer support certification program. So RSSs that actually work in the institution and can be employed outside of that. At my agency, we actually, our members, we actually have that as well. And it does do a lot to be able to encourage not only them to start using the skills for themselves, but then how they start utilizing that. As a workforce, I mean, peer support's very valuable. It does a lot in being able to de-escalate a lot of things. It does a lot of those really instrumental pieces. As far as recidivism, it depends, because you are entry level. So workforce-wise, you really have to be able to know that you're gonna come in kind of at the entry level and how to build that skill. So it's a long term, but I know for a lot of individuals that come through our peer support program that don't want to do day labor. They don't want to do the same thing that they did before because they're just not in the same spot or they can't do it. It is a wonderful option to get them working in recovery, talking about their own recovery in a new way and talking about their own identity in a new way. So it does a lot. There's no actual statistics about peer support and recidivism. That would be an interesting study. But I think it goes a long way in how it really helps somebody identify their role in the community.
Do we have time?
A little bit.
I'll just tell you that I totally agree with you. We have probably the largest national peer support organization in the country, and a lot of the people that are full-time employees with us were in jail or prison. We actually run the peer support for the Federal Bureau of Prisons for anyone in a reentry center, which is over 14,000 people. We have already hired a number of those people. Once they get out of probation, they can work for the BOP. We did a pilot with the GEO group in Florida. We had 178 people go through for a year. Only 3 people went back, and we actually hired 3 of those individuals as full-time coaches. So I think we can absolutely build our own workforce, and there's a lot of other things that we can do with these people once they get trained and once they go through the certification and all of that.
Thank you so much, everyone, for attending, and thank you to the 4 of you for being here, but also all the work that you do.